Hi friends, so now we are going to be starting with hematology. So this is one of the very important topics that you're going to be studying in path as well as medicine. So I've tried to integrate almost everything about RBCs, WBCs and then platelets, and in the end we're going to be talking briefly about transfusion medicine as well and a few concepts about blood grouping. Alright, so that's all going to be covered here. In the exam, actually if you see, the contribution of path to any exam, a lot of the questions can be solved if your foundation is strong, if you've integrated well, but a big chunk of it, a large fraction of it is from hematology, which is core path. So this is what is going to be very, very important if you just take distribution of path alone. So very important unit considering all the other systems. Okay, so let's begin then with the basics of hemat here. So what I'm going to be talking about first is the RBCs. So here what you want to remember is this is how the RBCs are forming. So from the hematopoietic cells you have the pro-erythroblast, also known as pro-normoblast. Remember, this is the first cell. This is the first cell where I can see the presence of hemoglobin, and that is on an electron microscope. Then we have the erythroblast or the normoblast, which further has three types. So you have basophilic, polychromatophilic and orthochromatic. So this is what you want to remember as BPO. So apart from BPO, you can also remember these as early, intermediate and late normoblasts. So here the question comes, which is the first cell wherein you can see the presence of hemoglobin on light microscopy, and that is intermediate. So that is your first where hemoglobin can be appreciated on light microscopy. So this is basically polychromatophilic or intermediate normoblast or erythroblast could be given in the options. After that you have reticulocyte. The one-liner for reticulocyte is this is the first cell to be coming in the blood circulation. So this can also be seen in blood in the last stage. As you can see, it spends 3 days in the bone marrow and then 1 day in the blood. So in its dying stages, it's going to spend its life in the blood. Now, the amount of reticulocytes that you see in the circulation is also something very important, because that helps us know whether it is hemolytic anemia, RBCs are getting destroyed after coming into circulation, or it is a bone marrow failure where the reticulocytes are only not coming. Alright, so whenever you hear something known as RPI, that is the reticulocyte proliferation index, remember, if it is high, this is hemolytic anemia. If it is low, it is something to do with bone marrow which is not producing enough reticulocytes. Alright, so this is about that, and finally you have the RBCs after losing all of its organelles. Okay, so this is what you want to remember. So in essence, first hemoglobin on electron microscopy, pro-normoblast. First on light microscopy, intermediate, BPO, intermediate normoblast. Reticulocyte comes in, and how do we see reticulocyte? One more question here is on supravital staining. So you got to do supravital staining in order to visualize reticulocytes. Alright, so that's also one more thing. Now let's talk about bone marrow biopsy and aspiration. This is one of the repeat questions from last year. So what you want to remember is what is aspiration, what is biopsy. So these two needles are your aspiration needles. Their name is Salas and Klimas. So they end with A, meaning bone marrow aspiration. Alright, so here when you see this side flange, this is Salas needle, whereas when you do not see anything on the side, this is Klimas needle. Alright, so you have Salas and Klimas. A is what gonna tell you that it's aspiration. On the other hand, this is your core bone marrow biopsy needle. Previously, we used to use the Jamshedi's needle, so that is what is typically asked. Where is Jamshedi's needle used? That's a completely metallic tube, but nowadays this is the core bone marrow biopsy needle which is used for bone marrow biopsy. What is the preferred site? So in adult, remember, it is posterior superior iliac spine, whereas in a child it is tibia. Very, very important. Is low platelet a contraindication? This is a question from last year which was asked as an all except question. So you want to remember that in any other procedure like a lumbar puncture or any other procedure that you are doing like a biopsy, low platelet becomes a contraindication because there is very high risk of bleeding. But then why are you doing a bone marrow biopsy? Because you want to find out causes of low platelet or any other low blood cell, right? So in this case, you cannot have low platelet as a contraindication. So 50,000 is not the cutoff like we have for others, but if it is below 20,000, then you would want to transfuse and then do the biopsy. So what you want to remember is that it is not a contraindication. It is not a contraindication to bone marrow aspiration or biopsy. That would be the correct statement here. Okay, so now we talk about RBC disorders. So there will be one image given to you and there will be a long question stem describing the scenario. If you can crack the image, you know, your question becomes very easy. So that's what we are going to do. We are going to talk about different diseases through the shapes. Okay, so the first shape that you're seeing here is an elliptical shape. So this is an RBC that is seen in hereditary elliptocytosis. All right, so this is what we see in elliptocytosis. Here you have a mutation in the membrane protein, which is what? Which is spectrin. So this is an RBC membrane disorder. It is a hemolytic anemia. Similarly, here what you see is a spherical RBC. So this is a spherocyte. A spherocyte is seen in one, hereditary spherocytosis, a similar spectrum disease like elliptocytosis. So this is hereditary spherocytosis. Here the mutation is in ankyrin. So you want to remember that S and S don't stick together, vowels don't stick together here. So wherever you have S, there is elliptocytosis. Wherever you have spherocytes, you have ankyrin. So just remember this cross mnemonic here. Apart from that, you also want to remember that in a spherocyte, what happens is overall the surface area reduces, and that is why you have the mean corpuscular hemoglobin concentration increasing. So in HS or in a spherocyte, remember that the concentration is higher. Now, even though HS is a very specific cause of spherocytes, the more commoner cause of spherocyte is actually autoimmune hemolytic anemia. So in that you would see a spherocyte more commonly. You can also see it in G6PD. All right, so G6P deficiency also you're gonna be seeing spherocytes. So this is what you want to remember as far as a spherocyte is concerned. Now let's just finish off hereditary spherocytosis right here. So here what you want to remember is that there is an EMA binding test. And when we test the osmotic fragility, these cells are very fragile. Osmotic fragility is increased. So how you want to remember is that Hema is a girl who is fragile. Alright, so Hema is fragile. So HEMA fragility increased. Alright, so that is our mnemonic for hereditary spherocytosis. Okay, so this is all about this. Now let's go to the next set. What you are seeing here is a large cell with a large surface area. This is what is your macrocyte. So here you are seeing macrocyte. Now remember, not all macrocytic anemia is megaloblastic anemia. So what is the criteria to call something megaloblastic anemia? We have to look at the neutrophils. So if you see that in the neutrophils you are seeing more side lobes. So if the number of lobes are more than 5 in 5% of the cells, or they are more than 6 even in one cell, that is a definition of megaloblastic anemia. Alright, so that is megaloblastic anemia for you. Apart from this, what you want to remember in megaloblastic anemia is you can also have fine basophilic stippling. Alright, so I'm going to write that in red because usually the moment you hear basophilic stippling, you're going to think of sideroblastic anemia. So now you want to remember that if it is coarse basophilic stippling, it's sideroblastic anemia. We'll talk about it. But if it is fine, it can also be seen in megaloblastic anemia, which is associated with B12 and folate deficiencies. Alright, so this is about the macrocytic or megaloblastic anemia. Next, very important, what you are seeing here are the target cells. Yes, so these are target cells. What they are also known as are codocytes. Okay, so they can give you this option, codocytes. So you want to know that a lot of these coders who are working on a lot of apps and all, they have targets, right? That today I have to do this, today I have to do this. So coders have targets, but they are always on their screen and their screen time is so much that their moms will tell them, take a halt, take a break. Okay, so you have to remember halt for codocytes and target. Okay, so what is halt? Halt is HBC disease, A for asplenia, L for liver disease, and T for most important, thalassemia. Alright, so thalassemia is the most important cause. T for thalassemia, T for target, and you remember halt as our story. Okay, so this is target cell. Then what you have are very easy, sickle cell, right? So these are your sickle cells, also known as drepanocytes. How to remember this? Patients who have sickle cell disease, are they predisposed to a lot of infections? They are, right? Because they are anemic, they have a lot of infections. So whenever you're doing any procedure, you want to drape well. Yeah, you want to clean and drape well in order to maintain sterility. So that's how you'll remember sickle is drepanocytes. Apart from that, what else you can see in sickle cell is the spleen becomes contracted. So there is autosplenectomy in the late stages. So with that asplenia, what are these bodies that you're seeing? So these bodies are known as Havel-Jolly bodies. Very, very important. These are Havel-Jolly bodies that you will see in asplenia, which is basically because of end stage sickle cell anemia. Okay, then two very, very important differentials you want to understand. So here you can see all RBCs clumping, whereas here they are stacked in one line. So when they are clumped like this is autoimmune hemolytic anemia. Autoimmune hemolytic anemia, let's just finish it right here. You are seeing this RBC agglutination. Here you are gonna have direct Coombs test positive. Okay, so this is frequently tested. The moment you hear Coombs test in an anemia, think of autoimmune hemolytic anemia. You have warm and cold autoimmune hemolytic anemia. Warm is associated with IgG, whereas cold is associated with IgM. Warm hemolytic anemia has several risk factors like SLE, CLL, certain drugs like beta-lactams, whereas IgM, very important, is associated with mycoplasma and EBV, infectious mononucleosis. Alright, so this is again very, very important. Mycoplasma and Epstein-Barr associated with cold autoimmune hemolytic anemia. Alright, in fact with CLL, I'm just gonna write an extra point here that is known as Evans syndrome. So Evans syndrome is CLL, which is associated with autoimmune hemolytic anemia plus ITP. So there is hemolytic anemia as well, and there's thrombocytopenia as well. So this is Evans syndrome. Fine. On the other hand, what you're seeing here is these RBCs stacked together. This is known as rouleau formation, right? So this is Rouleau's formation, which is seen in multiple myeloma. Yeah, so pretty hectic slide, but we have integrated everything here. So once to revise quickly: elliptocytosis, spectrin disorder, spherocytosis, and Guerin disorder. Remember, hema is fragile. You have megaloblastic anemia with B12 and folate. Seeing the increased number of side lobes is very, very important. Target cell or podocytes, remember, halt, drepanocytes and Havel-Jolly bodies. Agglutination in AIHA, Rouleau in multiple myeloma. Okay, so now starting with the next set, what you are seeing here are acanthocytes, also known as spur cells. All right, so these are also known as spur cells. Remember, these are going to be irregular processes. Where do you see acanthocytes or spur cells? So you can see them in A beta lipoproteinemia. Yes, so A beta lipoproteinemia we have also discussed in biochemistry. What you're going to have here is low levels of LDL because you don't have apolipoproteins to absorb. So this is also associated with spur cells, and you also want to remember vitamin E deficiency can also show you acanthocytes. Apart from that, when you see that there are regularly spaced projections, these are known as echinocytes or also known as Burr cells. Okay, so you want to remember R for regular, R for regular and R for renal failure. Okay, so you want to remember R for renal failure and BU for burns. All right, so the Burr is helping us so much. R for regular, R for renal failure, BUR for burns. And one more condition that you want to remember is pyruvate kinase deficiency. So there are two enzyme deficiencies that can lead to hemolytic anemia. One is G6PD that we've already seen, and another one is pyruvate kinase deficiency. The only thing about this you want to remember is echinocytes or Burr cells. Then what you are seeing in this condition are these teardrop cells. It looks as if the RBCs are crying. So these are teardrop cells, also known as dacryocytes, right? Just from the tear you can remember dacryocytes. Where do you see these dacryocytes and why are the RBCs crying? Because they've been pushed out of their houses. Their houses were bone marrow, and now suddenly something is living in the bone marrow. Maybe it is myelofibrosis, or it's a cancer, or it's a granulomatous disease, but these RBCs have been pushed out from their houses. So So this is seen in what we call this as myelophthisis. Anytime there is replacement of the bone marrow with anything other than the bone marrow cells, it is known as myelophthisis, which could include myelofibrosis or granulomatous disorders, or it could be metastasis. Okay, so this is teardrop or dacryocytes. What you see here are these helmet cells or schistocytes. Very, very important. So these are formed anytime you're going to have any sort of hemolytic anemia which is happening inside the RBCs. They're getting damaged. Trauma is happening, so they need to wear a helmet. Yeah. So this is seen in traumatic cases like microangiopathic hemolytic anemia or macroangiopathic hemolytic anemia. So what you want to remember for me is MAHA. It could be microangiopathic or macroangiopathic. Okay. So here what we are going to have could be causes. So microangiopathic could be because of DIC, TTP, HUS. These three letter words, three of these go together in micro. Small words, so microangiopathic hemolytic anemia. If the insult happens in main vessels, this could be because of prosthetic metallic valves. Alright, so this is macroangiopathic hemolytic anemia. Alright, so this is about helmet or schistocytes. Then what you are seeing here are bite cells. Doesn't it look like somebody has taken a bite of the RBCs? So these are bite cells, and you want to remember how did they take a bite? They first put some Heinz ketchup on the RBC and then we took a bite. We don't want to just eat it without ketchup. So this is Heinz body. So you can see the Heinz bodies in RBCs and bite cells on the peripheral smear, and this is all seen in G6PD. Yeah, so what happens in G6PD deficiency? You do not have the NADPH. If you remember biochemistry, this we have learned already, wherein I told you in the HMP shunt, if G6PD is not there, you're not gonna have NADPH. If NADPH is not there, there's nobody to protect the cell from oxidative stress. Yes, so because the oxidative stress can come through fava beans, through maybe some drugs like anti-malarial drugs, what you're gonna have during those time is hemolysis. So during the times of oxidative stress, you're gonna have hemolysis. Okay, so that is what is very important. In G6PD, you can have intravascular plus extravascular hemolysis. Remember that one point as well. And what you see here is the denatured RNA. So you are seeing denatured RNA, and that is why Heinz body can only be seen on supravital stain. Okay. So this is all you want to know about G6PD. Then what you see here is the basophilic stippling. Remember I was talking to you about this in megaloblastic anemia. So what you are seeing here is basophilic stippling. So this is basophilic stippling, which is coarse basophilic stippling. Where this is seen as sideroblastic anemia. So this is sideroblastic anemia. As the name suggests, here you have excess of iron. You have too much of iron. Why? Because heme is not forming. So here you have a defect with the heme synthesis. Alright. So the most common cause of inherited X-linked sideroblastic anemia is the enzyme ALA synthase is not there. Or the other reason could be you have lead poisoning, which blocks the enzyme. This also we have seen in biochemistry. So it can block the ALA dehydratase and ferrochelatase, two enzymes it can block. Or you could have B6 deficiency. B6 is a cofactor for ALA synthase. If that is not there, pyridoxine is not there, again you'll have heme synthesis which is impaired. Alright, so this is very, very important. In addition, what you're seeing here is on the bone marrow, when you do this Prussian blue or pearls staining, you're gonna see all of these iron. So this is what is known as a ringed sideroblast. Okay, so a ringed sideroblast, they can show you this image based question. These are all findings of sideroblastic anemia. Okay, so if you just do and revise these two slides, almost all of your questions of RBC disorders are sorted. So now let's do an approach and let's fill in the blanks with the remaining things and bring everything together. So in anemias, we divide it. The first step is the conventional teaching would be in this order itself, right? I've kind of mixed it up, but what you want to do is, I've done the most important stuff, now we are just aligning it. Okay, so microcytic anemia is where the cells, the MCV is less than 80 femtoliters. So here microcytic, you want to remember the DDs as Sita. Alright, so that is what we remember, Sita. So what are the DDs of microcytic anemia? One is sideroblastic anemia. So now you will tell me, do you know everything about this? Yes, I know almost everything about it. I is iron deficiency anemia, T is thalassemia, and A is anemia of chronic disease. So these are the ones which are going to present with microcytic anemia. Let's try and finish this off first. So what they can give you is this peripheral smear and they can ask you to interpret it. And this is in fact a repeat question. So what you're seeing here is that the pallor in the RBCs is too much. Remember, normally only the central 1/3 should be pale. So here you are seeing that the RBCs are hypochromic. Normally the RBC would be equal to the size of a lymphocyte nucleus, and you see how here there are so many RBCs who are smaller. So obviously you can't look at it and say that this looks around 70 femtoliters. You can't do that. You don't have that superpower. So we compare with the nucleus of the lymphocyte. So I can also say that these are microcytic cells. In addition, can you see how they have different shapes and they have different sizes also? So this is an isocytosis, and in a numerical form we can say that the red cell distribution width is increased. So all of these findings together forms the hallmark of iron deficiency anemia, and this is something which you cannot miss on a peripheral smear. Alright, so this is a question you cannot get wrong. Now how do you go about the iron profile? You found out that there's microcytic anemia and they give you the iron profile. How can you distinguish? So when you find serum iron is low, TIBC is high, meaning the total iron binding capacity, we want more iron. Ferritin is low and transferrin saturation is low, means body overall is deficient in iron, the capacity is increased. So this is simple iron deficiency anemia. If you find that iron is low, TIBC is also low, meaning we do not have that total iron binding capacity which is increased. You have ferritin which is high and you have transferrin which is low. So here the hallmark is ferritin which is increasing, which is a marker of inflammation. So this is anemia of chronic disease. Alright, very important. Why transferrin saturation and transferrin is low is because in anemia of chronic disease you have hepcidin which is raised, and anytime hepcidin is raised, remember you're gonna have reduced absorption from the mucosa, and that explains the anemia of chronic disease. On the other hand, iron is high. The moment I see iron high, everything is gonna be opposite to IDA. TIBC is low, ferritin is high, saturation is so high. So this is sideroblastic anemia, as simple as it gets. There is no heme, so iron is too much. Okay. Now, iron deficiency anemia and Thal minor can have a lot of similarity in the iron profile as well. So how do you distinguish these? So for that, for the exam purpose, Menzer index is very important, and RDV if it's given, it's the easiest. So you want to remember in iron deficiency, like we saw, IDA is increased, whereas in Thal minor it is reduced to normal. Menzer index means what? So this is MCV by the RBC number. Alright. So here you take the RBC count and you take the MCV. Remember Menzer, so starts with M. So this is MCV upon RBC. Where is it less? So you want to remember thalassemia. It is thalassemia. So in thalassemia minor it is reduced, whereas it is increased in iron deficiency anemia. Right. Why that is because in thalassemia you have RBC count which increases. Alright, there is a slight increase in RBC, and that is why, because the denominator is increasing, overall it reduces. Okay, so this is about IDA versus Thal minor, because both of them are gonna have a low MCV, both of them are microcytic anemia, and that's why we are trying to distinguish. But the confirmation for all thalassemia, remember always, is HPLC, right? So HPLC is the investigation of choice for Thal minor. Here in thalassemia minor, what you're gonna do is an estimation of HbA2 which is raised. So in normal people it is less than 2% HbO2, but in Thal minor HbA2 increases. Remember, Thal major hemoglobin F increases majorly, but in Thal minor it's hemoglobin A2, so it's alpha 2 delta 2 chains which are increased here. Okay, so this is about microcytic. Now let's go back to our flow chart. Now if we have normocytic anemia, the most important consideration here is going to be aplastic anemia. Apart from that, in chronic kidney disease, because of EPO deficiency, you're going to have normocytic anemia. Then two overlaps. AOCD and iron deficiency anemia in certain cases could be normocytic. In early cases, it could be normocytic as well. Okay, so this is our non-hemolytic list. Takeaway is EPO deficiency and aplastic anemia. Now coming to the main exam important category, which is hemolytic anemia. We have already seen that the reticulocyte proliferation index is going to be high. Now, here it could be because of maybe an intrinsic damage in the RBC or because of extrinsic factors. Intrinsically, there could be a problem with hemoglobin. So, here you could have a problem with the globin chains not forming properly, that is thalassemia. You could have hemoglobin type not forming well, which could be hemoglobin C or S. You could have a problem with RBC membrane. So, you can have hereditary spherocytosis or elliptocytosis, as we have already finished this, or you could have enzyme deficiency, which I have already told you. So, in enzyme deficiency, you could have G6PD and you could have pyruvate kinase. Now, remember, all of these are inherited causes. The only acquired cause of an intrinsic defect is a defect in RBC membrane, wherein you have a problem with the phosphatidyl chains which are inhibiting the complement activation. I am talking about PNH, paroxysmal nocturnal hemoglobinuria. Remember, this is the only acquired cause of intrinsic hemolytic anemia and it predominantly causes IVH. Very important, it causes intravascular hemolysis. We'll be talking about this. On the other hand, extrinsic causes outside the RBCs, the problems could be with MAHA, as we have already discussed. So, here you have microangiopathic or macroangiopathic, you're going to be seeing schistocytes, or it could be AIHA. So, AIHA and MAHA are the two causes. This also we have already done. So, here in autoimmune, you can have direct Coombs test, which is positive. We've done the causes of warm and cold. Warm is IgG, cold is IgM. Alright, so this is sorted. Now, let's quickly discuss what will happen in IVH and EVH. So, remember, whenever we have intravascular hemolysis, what you're gonna have is hemoglobinuria. Haptoglobin, because it is binding to so much RBC, it reduces. Hemoglobinuria, haptoglobin, very, very important. Apart from that, in EVH, what's gonna happen? Extravascular hemolysis. You have hemolysis which is happening and then all of that destroyed blood is going to become bilirubin in the liver. So, you can have jaundice, right? So, you're gonna have jaundice and you can have stones. You can have gallstones, which are your pigment stones. So, these are the manifestations. So, predominantly IVH, remember, is gonna happen in PNH and all of your causes of MAHA, right? So, these are your two categories where you're gonna see intravascular hemolysis. Okay, now let's just finish off all of the other important stuff from hemolytic anemia. So, first I want to discuss this osmotic fragility. So, whenever we see this osmotic fragility curve, whenever they're showing you hemolysis with percentage sodium chloride solution, remember, normal RBCs are gonna lyse if we reduce the concentration and make NaCl very hypotonic beyond 0.4%, alright, or 0.3%. But where you have reduced fragility, sickle cell anemia and thal major. So, remember, they have reduced osmotic fragility and they are going to survive and they are going to show lysis at even more hypotonic solution. So, remember to interpret this graph correctly. When it does not break at less than 0.4%, it's reduced fragility, whereas when it's breaking at 0.6%, it is more fragile, and we already know HEMA being fragile, so that's hereditary spherocytosis for us. So, you want to remember thal major and sickle cell anemia or thalassemia in general is going to have reduced fragility. How that can be tested to you is this image based question, which is known as Nestrov. What is Nestrov? So, this is naked eye single test tube RBC osmotic fragility. What I've done is I've taken two test tubes, one is normal, one is patient, and I've added hypotonic saline. Now, based on this, they'll ask you tell me which is normal. They'll mark it A and B and they'll ask you tell me which is normal. A is normal or A is thalassemia. So, here what it means is, when I take hypotonic solution of around 0.3%, normal cells are gonna die. They do not have decreased osmotic fragility, so they're gonna die and they're gonna lyse. So, whenever the cells are lysed, I'm gonna see the lines beyond it, right? There are no cells to block the view. So, I can see the lines, so this is normal. On the other hand, when it is not breaking, when it is still not breaking and the RBCs are blocking our view of the line, this is when I can say that the osmotic fragility is reduced. they have still not lysed, meaning this is thalassemia. Alright, so this is how you gotta interpret the Nastrov test. Now we talk about PNH, very important, paroxysmal nocturnal hemoglobinuria. So now you can hear certain names. Paroxysmal nocturnal. Why does this hemoglobin lysis occur in the night? So here you need to understand the pathophysiology, that in PNH what is deficient is this glycosyl phosphatidyl inositol. It is the GPI anchor, this GPI anchor which is holding together these complement binding proteins is deficient. So you have a deficiency of CD59 and decay accelerating factor or CD55. This is also known as MIRL. So basically both of these guys are inhibiting the complement activation, and inhibitors are absent, so you're going to have a lot of complement mediated lysis of the RBCs. So that's the pathophysiology you want to understand here. Because these complements are breaking the RBCs inside the blood, there's intravascular hemolysis. Complement activation further increases when the pH decreases. During the night, you have pH which reduces because of CO2 retention. Yeah, so you have pH which is reduced, and that is why it's more dominant in the night or any other condition when it is higher. Apart from that, one more important consideration, you can have pancytopenia here. So this is a very important condition where you can have bleeding because there is pancytopenia with thrombosis. Because there is complement mediated injury, there is endothelial injury, and we know the Virchow's triad, there will be thrombosis. So this is one condition where bleeding and thrombosis coexist. So one of the most common causes of death, this is a repeat question, most common cause of death in PNH patients is Budd-Chiari syndrome, which is obstruction of the IVC and hepatic veins. Lab score, we'll talk about lab score. It is low here. So lab score is low in two conditions. One is CML and second is PNH. So all three letter words together. CML, PNH, low lab score. Lab score is leukocyte alkaline phosphatase test. Okay, so this is something that you want to remember. Very important from AIIMS point of view or INICT point of view. This is so frequently asked. Two complications, aplastic anemia and leukemia. Both of these can occur. Both sides of the spectrum the story can go, and one specific treatment is monoclonal antibody which blocks C5, so the complement mediated activation is blocked, is eculizumab. The investigation of choice is flow cytometry, which I am showing you here. So they can show you this 55 and 59. Normally the cells should be here, but when you see that the cells are deficient in both, the cell groups would belong here. Alright, so this is all about PNH, very important, and that's why I have told you everything in detail here. Now let's look at the hemoglobin electrophoresis. So they can show you this image and they can ask you to interpret it. So first thing you want to remember is the order. So this is the anode which is positive and this is the cathode which is negative. So how are they arranged? So A for anode, A is closer to the anode. So you want to remember a fat Santa Claus. Alright, so that's our mnemonic here, a fat Santa Claus. So AFSC, that's how the order is from anode. So first of all, anode with A. So a fat Santa Claus, this is the order. So now let's interpret this. Whenever I see both of the bars are near AA, so both the chains are hemoglobin A. This is how your normal adult hemoglobin would look like. So what is A? A is nothing but the normal hemoglobin A of the adult. So this is how a normal person would look like. If you have one A chain and one hemoglobin F chain, this means that you are a normal newborn. Remember, in newborns the hemoglobin F concentration is very high. You know, in fetuses HbF is the main hemoglobin. This is alpha 2, gamma 2, and this is because their affinity is higher. Hemoglobin F has a higher affinity and that's why it's high in fetuses, and as soon as a fetus becomes a newborn, HbF will be high. Slowly it reduces. Okay, if you see S, HbS, what is HbS? So HbS is your sickle cell anemia. What happens here? Here you have a missense mutation. What is a missense mutation? So in HbS, instead of glutamate, there is valine. So when I remember, glutamate goes and valine is welcome. व से welcome, g से goes. So glutamate is replaced by valine because of a missense mutation. On the other hand, we have hemoglobin C. So hemoglobin C is also a missense mutation. Here the glutamate is replaced by lysine, and if you remember biochemistry, lysine is more basic, right? So because it is so much basic, that's why it's closest to the cathode. Alright, so I hope this explains things to you. So this is about HBC and HBS diseases. So when you see one A and one S chain, this means that you have sickle cell trait. One question from sickle cell trait, remember they have high risk of medullary type of RCC. Okay, so they have higher risk of medullary RCC. When you have both S chains, this is sickle cell anemia. When you have one A and one C, this is HBC trait. When you have both C, this is HBC disease, and when you have H and C, this is a combination of sickle cell with HBC. So this is HBSC disease. This can be asked as an applied question to you. Okay. Now let's talk about thalassemia. So thalassemia is where you have a defect in the globin genes. All right. So if you have a mutation in the alpha chains, what is going to happen? So remember, it's located on chromosome 16, and 16 you are going to have 4 alleles. So 4 ka square is 16. So remember, there are 4 alleles coding for the alpha gene, and that's chromosome 16. The mutation which happens here is deletion. It is the deletion which happens. So when you have only one alpha chain which is deleted, you're going to have no major problems. You have 3 genes which are functioning. So this is asymptomatic. If there are 2 genes which are deleted, it could be in 2 different chromosomes, or it could be in the same chromosome. So cis variant, where it's on the same chromosome, has slightly worse prognosis because it has higher risk of transmission in the future generations. Okay, so this is alpha thalassemia minor. Alpha thalassemia minor, remember, can be asymptomatic or they can have mild anemia. Then when you have 3 chains which are not there, you're going to have very little alpha. So lot of beta 4 accumulates, and that is going to combine these beta 4 chains. This is known as HBH disease. Very important. We have done S, C, and now H, and what they form are these golf ball inclusions. So these are your beta 4 or HBH disease golf ball inclusions. And if you have no alpha chain, can fetal hemoglobin ever form? When fetal hemoglobin is not forming, can the fetus survive? No. So that is your gamma 4 deposition known as hemoglobin baths, and this leads to in utero fatality. Alright, so this is also severe anemia, whereas this is in utero fatal. On the other hand, what is more common is beta thalassemia. So beta gene is coded on chromosome 11, and what you have here are splicing mutations. We have studied splicing in the biochemistry, where you remove the introns. So during that you have a splice site mutation. There are a lot of splicing mutations, a lot of variants of these genetic defects, and you can ask you a difficult question in name. What is the most common mutation that is seen in India? So you want to remember, it is IVS 125, wherein there is G to C chain transition. So this is the most common mutation in India. This sounds like something that INICT can ask. Okay, so this is about splice mutations. Now here there are only 2 alleles. So here you either have beta plus, where you have partially formed beta chain, or there's complete deletion. So when you have one which is intact, that's beta thalassemia minor. We already know what to do here. There's going to be HbA2 which is raised. On the other hand, when you have both defective, or one completely absent and one defective, or both completely deleted, that is your beta thal major. Intermedia can have variable manifestations, but major is the type where you have very high levels of HbF, because there are no beta chains. There is no alpha to beta 2, so there is no adult hemoglobin. So you have very high levels of HbF here. Very, very important. This is your transfusion dependent anemia. So here you're gonna have this extramedullary hematopoiesis, which results as this crew cut appearance we have seen in radiology, and you're gonna have these chipmunk faces again because of extramedullary hematopoiesis. So this is a transfusion dependent patient in beta thal major. Okay, so this is all about thalassemia. So now the only part which is left is macrocytic anemia, which is very simple. More or less it will be based with biochemistry. You will get questions integrated with B12 folate deficiency, and that's what we've already covered. So here all you want to remember is, if a cell is large, it does not mean it is always megaloblastic. That's the learning point here. If you see that the WBCs have increased lobes, only then you can say that it is megaloblastic. Alright, so that's the learning point here. So megaloblastic anemia, the two most important causes that you want to remember would be B12 and folate deficiency. The histories you already know. B12 is somebody who's probably a vegan. It could be somebody who has pernicious anemia. It could be somebody who has ileal disease, right? So these are the related things with B12 deficiency, whereas in folate deficiency you'll get somebody who's eating a lot of junk food, not eating green vegetables properly. So that would be the history. You would have somebody who's having a defect at what level? Iron fist bro. So it is jejunum, right? Somebody who has maybe say celiac spro or jejunal disease can have folate deficiency. So that's what we're gonna get here. If you have non-megaloblastic macrocytic anemia, the causes you want to rule out would include liver failure, and one very important cause is chronic alcoholic patients, right? They can also have non-megaloblastic macrocytic anemia. So this is all about the classification of anemias. With this we have completed RBCs pretty quickly. Now we go into WBC. So in one of the repeat exams you were asked to identify the WBC cell, so that's also very important. So this is the lineage of WBC and this is the order in which the cells are gonna mature, right? So this is the maturation order here. So what you are seeing here is the origin, the father, who is myeloblast. Alright, so this is myeloblast. We're gonna learn how to distinguish this from a lymphoblast in due course of time. So this is myeloblast. After myeloblast, what you're seeing here is a promyelocyte. A promyelocyte is rich in these cytoplasmic granules, which are or rods. Alright, so these are or rods. Remember, in AML, myeloblastic leukemia, we have a promyelocytic type which is M3, wherein you see this cell which is very much rich in or rods. Okay, so that's promyelocyte. After promyelocyte, because pro was the origin, so now this is your myelocyte. The feature of myelocyte is it's gonna have this D-shaped nucleus. So you wanna remember MD. Yes, so myelocyte is a D-shaped nucleus. Then it becomes a metamyelocyte. Metamyelocyte has this reniform or kidney-shaped nucleus. There's also something that you see in monocytes, isn't it? So metamyelocyte has this dependent kidney-shaped, and this can also be remembered if you integrate anatomy a bit. Do you remember how kidneys form from the metanephros? Yeah, so metanephros, metamyelocyte, kidney. That's how the world comes together. So this is metamyelocyte. When you see this ring here, this is known as the band or the stab form. Alright, and this is our mature neutrophil. So now, anytime the body has inflammation or the body has a lot of leukocytes, what's gonna happen is, due to sudden demand, body does not have the time to process each and every cell. So this is what is very important, that this processing might be affected, and that would result in the immature forms coming into the blood circulation. Alright, and that is what we know as the leftward shift, right? You must have studied this when we did appendicitis Mantrel score. There was left shift there. So this is left shift, wherein you have immature forms, band forms coming in, metamyelocyte coming in the peripheral smear. Alright, so I hope you get that. So whenever we have a left shift or you have a lot of WBCs, there are two main differentials. One is CML, maybe it's a tumor, chronic myelocytic leukemia, or there is leukemoid reaction which occurs in sepsis. How we distinguish them is on the basis of this stain which is known as leukocyte alkaline phosphatase, or the LAP score. Very important question that you want to remember, that LAP score is increased in leukemoid reaction, whereas it is decreased. I have already told you these two conditions, CML and PNH. These are two conditions where the LAP score is gonna be reduced. Okay, so this is all about the WBCs. Now we go on to a very important approach to pancytopenia. If you do this chart well, it's gonna help you solve a lot of MCQs, which I can guarantee you would have gotten wrong otherwise, because this gets very confusing. So you have to be very cautious. What are they giving? Pancytopenia without hepatosplenomegaly. Then You look at the buzzwords. Is there a dry tap? All right. And then they give you the biopsy. Look at the biopsy. Everything is empty. There are just fat cells that you're seeing. In a normal bone marrow biopsy, you would see 50% cells and you would see 50% of fat. What is the diagnosis? Aplastic anemia. What do you want to remember here? No hepatosplenomegaly. There could be pre-existing viral disease, there could be some sort of drug intake, radiation, those could be the risk factors. This is aplastic anemia. Also remember pure red cell aplasia, that is related with parvovirus. Alright, so parvovirus B19 can lead to a pure red cell aplasia. Now, if you see that hepatosplenomegaly is not there and instead of an empty marrow, you are having a hypercellular marrow, you are having these abnormal cell forms. What is the diagnosis? We are dealing with a case of myelodysplasia. There are a lot of syndromes associated and a lot of mutations associated with myelodysplasias. You want to remember two. So, the most common one in child is monosomy 7. You want to remember, children want to play alone till the age 7. Yeah, they like being alone. Mono 7. It is deletion 5q. Alright, so these are two mutations you want to remember. You can see on the marrow there are two kinds of cells. What you are seeing here is known as a pawn ball megakaryocyte. So this is a pawn ball megakaryocyte, and what you see here is pseudo-Pelger Ute abnormality. So this is pseudo-Pelger Ute abnormality. Alright, so these are two named cells that you want to remember with myelodysplasia. Alright, so no hepatosplenomegaly. Now when you see hepatosplenomegaly and you get a dry tap, there are two possible conditions, both being very, very important. If there is a dry tap and look at the peripheral smear here, it is showing you teardrop cells or dacryocytes. Do you remember this? Why are RBCs crying? In addition, you can see that there are some blasts which have come in. There is anisopoikilocytosis, and the blast coming in is known as leukoerythroblastosis. So immature forms have been dragged out of their houses. RBCs have been dragged out of their houses. Poor things are crying. What is going on? This is myelophthisis. Yeah, do you remember this? So this is when you have an infiltrative disorder in the bone marrow. Maybe it's a malignancy, maybe it's a granulomatous disorder, or it's just myelofibrosis. You will get a dry tap because everything has been pushed out into the peripheral smear. Alright, so remember two buzzwords, dacryocytes and leukoerythroblastosis. On the other hand, if you hear the buzzwords, dry tap is there is massive splenomegaly but no lymph nodal enlargement, and you hear this stain, that is TRAP positive. You can see these cells which have these projections. What are we dealing with? We are dealing with a case of hairy cell leukemia. This is one leukemia which has massive splenomegaly and it involves the red pulp. Everything else where spleen is involved, it's going to be the white pulp. This is one exception. Okay, so that's the first learning point. So we did TRAP. And also remember dry tap. If I add it, it becomes trap. Again, you do some mixing, you can form the word BRAF out of it. So this is BRAF mutation that you have. The markers are what are very routinely asked. I'm going to mark that in red. So the best marker is annexin A1. You want to remember annexin A1. Do not confuse this with annexin 5 or annexin V. Annexin V is what you see is a marker of apoptosis, right? So remember these two. So there is annexin A1. What are the CD markers? Remember CD11C, 25, 103. So 11, then you go to double series, then you go to 3-digit series. 11, 25, 103. What is the biopsy marker? On the biopsy, you're gonna be seeing a fried egg cytoplasm. Where all have we studied fried egg? We've already done this in micro. So we see fried egg in mycoplasma. We see fried egg appearance in oligodendroglioma. So this is hairy cell leukemia. What is the drug of choice? Drug of choice is cladribine. Alright, so cladribine is the drug of choice for hairy cell leukemia. So very important. Now these were two conditions where hepatosplenomegaly with dry tap was there. If you see a hypercellular marrow, we go into a whole category of leukemias. Okay, so that diagnosis is made, pancytopenia, hepatosplenomegaly. We are dealing with a case of leukemia. Now what is is it? So this gives you 4 DDs, AML, ALL, CML and CLL. So here remember the acute, obviously the presentation is going to help you to distinguish. If you have a child, it is likely a case of ALL, whereas if you are dealing with an adult, it is likely a case of AML. That is how the age strongly relates with the diagnosis. If you look at the cells, how are the lymphoblasts? So the lymphoblasts, remember, are gonna have scanty cytoplasm. You can barely see any cytoplasm, the nucleus is so large. Apart from that, if you do the staining, this is gonna be PAS positive. We all know what are PAS positive, we've discussed this. This is also diastase resistant. Everything is diastase resistant except glycogen, isn't it? Then if you see that there are these OR rods, the cytoplasm is rich in these OR rods, you can see these cells, and you do the staining, myeloperoxide or Sudan black is positive. Alright, so this is how you're going to identify lymphoblast and myeloblast. Once your job is done, you have the diagnosis, it's either ALL or AML. So now we got to go into the details of it. Let's finish off ALL. In ALL, the question comes about prognosis. So what has poor prognosis? So remember, this table here is poor prognostic marker. So extremes of ages, either the child is an infant or older child, more than 10 years, poor prognosis. T-cell ALL has a poorer prognosis compared to pre-B cell ALL. Alright, so B cell has a good prognosis. Let's just compare these together. Alright, so these are both ALL prognostic factors. The marker of a T-cell ALL is acid phosphatase. It's going to be acid phosphatase positive. If you have presence of mediastinal lesion, brain lesion or testicular lesion, that's again poor prognosis. L1 is good prognosis, L2 is bad prognosis. Hyperdiploidy, good prognosis. Hypodiploidy, bad. T1221 is good, whereas 922, 411 are bad prognosis. Alright, so how to remember? One more thing, girls have a better prognosis than boys. So you want to remember, girls sometimes can be hyper. Girls are usually toppers in their class, and two ages you remember of girls which are very important. One is 12 years, second is 21 years. Alright, so you can just remember these two ages, 12, 21, female, L1, hyperdiploidy. Alright, so this is about good prognosis. Now something must be remembered here. There is Philadelphia chromosome. I am sure you know that 922 is Philadelphia chromosome. But is this the same as the one we study in CML? Answer is no. So there is a difference in this Philadelphia chromosome in terms of the weight. Alright, so here it is a 190 kilodalton Philadelphia chromosome, whereas we can also see this in CML, as you all know, which is typically 210 kilodalton. And just to give you an extra edge, even in CNL, chronic neutrophilic leukemia, you have pH which is 230 kilodaltons. Alright, so these are 3 DDs where you can have 922 mutation, 922 translocation. Alright, so this is CML, CNL and ALL now. Alright, so there are 3 DDs, very important extra edge for INICT. Alright, so this takes care of ALL. Now let's venture into AML. Alright, so we need to do the FAB classification of AML here. Very, very important. They ask you the subtypes and the relevant features. So M0 is undifferentiated. So if I do a myeloperoxidase, it's going to be negative. M1, nothing much except for the fact that myeloblasts are seen here. M2 is the most common type. So you want to remember, this is the most common type. How many eyes do we have? 2 eyes. So you want to remember, this also produces chloromas. The most common site of chloromas are the orbits. Apart from that, the translocation. So 2 is a multiple of 8. So you remember 2 T821. Alright, so 821 is M2. This is the most common type. Most important for exam, promyelocytic leukemia, APML, acute promyelocytic leukemia. You see these faggot cells which are so rich in OR rods. So these are OR rods which we see in these faggot cells, which are these promyelocytes. Very important, M3 has 3 letters. This type can predispose to DIC. Mutation, 3 is a multiple of 15. So you remember T1517. Alright, these mutations, these translocations are very important. So T822, M3, 15, 17 is M3. It also responds, what is the treatment? It responds to ATRA, which is trans-retinoic acid. Apart from that, arsenic oxide can also be used. So this is about ATRA. So this is M3. Then let's talk about M4. So M4 and M5 are where you have monocytic differentiation. So in M4 and M5 you're gonna have monocytic differentiation. Remember the mutation for M4, there is an inversion 16, yeah, 4 4s are 16, so that's how you can remember inversion 16. So 3 mutations we've done. M5 and M4, both of them, anytime you have monoblast, remember you can have leukemia cutis. You can have subcutaneous or infiltration of gums with the leukemic cells, alright. So cutis and gums infiltration is seen in M4, M5. As far as M6 is concerned, the only thing is there is erythroblastic differentiation. M7, you want to remember, there is megakaryocytic differentiation. This is the type that is specifically seen in Down syndrome, particularly in children less than 3 years. This is the most common type. Also, you want to remember this is associated with a dry tap because there is fibrosis here. Okay, so this is an exception to the version which we did earlier. This is the only type of leukemia where you're going to have a dry tap because it's associated with myelofibrosis. Okay, so this is the FAB classification. Now let's go to our chronic category. So here you also get a lot of questions. So we have CLL and CML. Look at these two smears. If I tell you, you have to compare this with a college party and a school party. Does this look like a school girl or a convent girl appearance that everybody is wearing the same uniform, all the cells look pretty similar? So this has been likened to that and this has been called as a convent girl appearance. On the other hand, look at this. It looks as if it's a garden party. It's a college party where everybody has worn whatever they want to. So this is known as a college girl appearance. This is an AIMS question from last year. Okay, so this is about CML and CLL. In CML, you're going to have all kinds of cells in the peripheral smear. You're going to have immature cells. You're going to have a lot of blast cells. Okay, apart from that, in the bone marrow, you can see these gaucher. They almost look like the tissue paper appearance of gaucher, but because they are not gaucher, we call them pseudo gaucher cells. Investigation of choice here, what are we seeing? We are doing a FISH to see the famous T922, something that we've already done with ALL. This is the OG Philadelphia chromosome, right? So this is what is the BCR ABL translocation that we are having here, BCR ABL fusion. This is T922. All right, remember actually in alphabetical order, 9 has ABL and 22 has BCR. So it's arranged in alphabetical order. Okay, so this is about CML. About CLL, what you want to remember, there are lots of things. So CLL, we are also going to study in lymphomas as well. So it's either called CLL or SLL. There we are going to study smudge cells and a lot of other deletions as well. So let's do all of these one-liners. Overall, what's the most common in children? It is ALL. What is the most common in Downs? So this is a trapper. That overall in Downs it is ALL, but if they mention less than 3 years, then it becomes the specific subtype, that is AML M7. Okay, what is the most common type in adults? We have already seen it is AML. The most common with radiation again is AML. This I have also taught you in radiology. Now when I talk about elderly, West, no relation with radiation, it is all CLL. So we want to remember all. CLL is all. When you are in doubt, please don't read this as ALL, lymphoblastic leukemia. This is everything. CLL is all. I'm just going to rub this. So CLL is all will be positive here. Okay, that's what I mean. So deletion 13q is also CLL. Alright, so this is about the questions from leukemia. Now let's go to myeloproliferative disorders. So here we have polycythemia vera, essential thrombocytosis, CML we have already discussed, and myelofibrosis. So let's just do this category here. Polycythemia vera, predominantly it is the RBCs which increase, but you want to remember that erythropoietin is actually low. Because this is tumoral, EPO in response becomes low. Here you also have WBCs and platelets which are increasing, and this is frequently associated with JAK2 mutations, and that's why we can give a JAK2 inhibitor, that is ruxolitinib. Alright, so ruxolitinib is a specific JAK2 inhibitor. Okay, so that is what is the drug that can be given for polycythemia vera. This you can remember as new drugs. Then when we talk about essential thrombocytosis, there is only platelet which is raised, by everything else is normal. The mutation is seen in around 30 to 50% cases. Two very important features: anytime platelet is raised, you are going to see this manifestation known as erythromelalgia, wherein you have the constriction of the peripheral vessels, and you will have, because of the stasis and the increase in the amount of platelet, you're going to have this very red vasoconstricted appearance. Alright, so this is what you want to remember. And apart from that, so many platelets are being produced, the megakaryocyte is under a lot of stress. You see these processes which is known as a staghorn megakaryocyte. Alright, so this is a staghorn megakaryocyte that you see in essential thrombocytosis. Apart from that, one more thing, because in polycythemia you have a lot of RBCs, you're gonna have aquagenic pruritus, which is induced by a hot bath. Okay, so that's a very specific buzzword that you can remember, that you have aquagenic pruritus in polycythemia vera. Then when we talk about CML, RBCs are going to be low, but WBCs and platelets could be high. Here we do not see JAK2 mutations, we frequently have BCR-ABL like we've already seen, whereas in myelofibrosis you're going to have pancytopenia, everything is going to be low. Again, this could be seen in 30 to 50% cases. Alright, so this is how you have to approach myeloproliferative disorders. So now let's talk about the approach to Hodgkin's lymphoma. So the first thing is that when we talk about Hodgkin's versus non-Hodgkin's lymphoma is more going to be for the lymph nodes. The extranodular involvement is going to be much lesser, right? So that's how you end up with a differential of HL. Now differentiating the different types. So here you have to look at the RS cells, the Reed-Sternberg cells and the markers. So when you have CD1530 positive, this is the classical Reed-Sternberg cell wherein you have 1530 positive and associated frequently with EBV LMP. So this is the Epstein-Barr virus positivity that we get with these types. So now you have 4 different possibilities with a classical Hodgkin's lymphoma CD marker pattern. Here you have to further look at the clues. So if the clue is mentioning collagen nodules or lacunar cells, these empty cells, this is the most common subtype in the world, which is known as the nodular sclerosis. So the collagen nodules will be a big clue here. Nodular sclerosis variant of HL, which is the most common type in the world. If they tell you it's a mixed background, there are no collagen nodules, and what you see is the classic owl-eye appearance, right? We've talked about this in CMV as well. CMV also has this owl-eye appearance, but it's basophilic. Here, the cell is eosinophilic. So this is what is very important. So when the background is mixed with a classical RS, this is the mixed cellularity variant of Hodgkin's lymphoma, and this is the most common type in India. Right, so in our country, this is the most common type. You can remember we have a mixed population, so mixed cellularity, most common. The next part where you have a lot of lymphocytes in the background, and what you see is a single nuclear, mononuclear Reed-Sternberg cell. This is lymphocyte rich, right? Do not confuse this with lymphocyte predominant. This is lymphocyte rich, and when you have low lymphocyte with a pleomorphic mummified Reed-Sternberg cell, this is what is called as lymphocyte depleted type, right? So these are the 4 subtypes here. Coming to the one which is going to be more likely to be asked, wherein you don't have the typical 1530 positivity, but you have 2045 positivity and BCL6 positivity. EMA is also a marker which can be positive, but EBV is not associated with this type. The kind of cells you see are popcorn cells. Very, very important clue. And how you remember it is P for popcorn and P for lymphocyte predominant. So this is the different subtype here with the different CD markers and BCL6. So how you remember popcorn, eating popcorn, watching movies always has a good prognosis, best prognosis. So that's why lymphocyte predominant has the best prognosis, right? So this is how you will remember Hodgkin's lymphoma. Now you also want to remember that we follow the modified Ann Arbor staging for Hodgkin's lymphoma. So what is this staging? Here stage 1 is if only one site of lymph nodes is involved. If you have two sites of lymph nodes which are involved, like cervical and axillary in this case, on the same side of diaphragm, it is stage 2. If there are multiple groups of lymph nodes or two groups of lymph nodes which are involved on two sides of the diaphragm, that's stage 3. And when you have extranodal sites like liver in this case, bone in this case, it becomes stage 4. The treatment regimen you want to remember for Hodgkin's is ABVD. So you give anthracyclines like doxorubicin or daunorubicin is preferred. Give bleomycin, you give vinblastine, and D for dacarbazine. So this is the ABVD regimen here in Hodgkin's lymphoma. Okay. Now let's go to non-Hodgkin's lymphoma. If you just study it like one after the other, you're gonna go crazy and never remember anything. So for this, first let's sort out the translocations in the easiest way possible. This is again one thing I'm very proud of, is this mnemonic here. Okay. So anytime you see 8 in the translocation, it has to be Burkitt's lymphoma. So that's our key here, that B looks a lot like 8, isn't it? Yeah. So anytime you see 8, it is Burkitt's lymphoma, except 821. Do you remember 821? We've done this in AML M2. So except this, anytime you see 8 in the translocation, it's Burkitt. So the famous ones are 814, 822, it could be 28. So any permutation combination with an 8 is Burkitt's lymphoma. Let me just tell you what is carried on each of these, so you can also expand the translocation. So on 8 you have c-MYC, and that will also help you remember that c-MYC is what is mutated in Burkitt lymphoma. 11 is cyclin D1. So 1 is 11, cyclin D1. 14 is nothing special, it is heavy chain of immunoglobulin IgH, and 18 is BCL2. So once you know this, even the markers become very easy after you remember the translocation. So now we've already done the easiest, which is Burkitt. Now take these three numbers together. What are the two margins? 11 and 18 are the two margins, right? So remember T11, 18. What is this? When we've taken the two margins, this is marginal zone lymphoma, also known as maltoma. So this is marginal zone or maltoma, taking the margins T11, 18. If you have translocation 11, 14, the first number is 11, EL. And what does mantle end with? It ends with EL. Yeah, so you remember mantle cell lymphoma is EL 11, 14. And what is left? T14, 18. So 14, 18 is 4 for follicular. Okay, so this is follicular lymphoma. I hope you can remember this now. So follicular lymphoma is 4, and the marker here is gonna be BCL2. In 11, 14 it is mantle. So you want to remember with mantle, cyclin D1 is what is prominent, and 11, 18 is both the margins. So you remember everything is negative here. Alright, I hope you'll remember 11, 18 margins, marginal. 11, 14 EL, mantle, 14, 18 4 follicular. Okay, so this is about the translocations. I hope you remember this forever, for the rest of your life. On the other hand, they can also ask you about the origin. So here remember the naive B cells would be CLL/SLL, whatever you want to call it. Mantle zone surprise gives rise to mantle zone lymphoma. So this we are not bothered with. Marginal zone surprise gives rise to marginal zone. Plasma B cell gives rise to multiple myeloma. So I'm pretty sure all of this you can get on your own. So the only thing that I have taught you is naive B cell are CLL, SLL, and whatever is left is germinal center. So what all is left? We have follicular, we have diffuse large B cell, and we have Burkitt. So the other three are arising from germinal center. So this makes a very good all except question. All of the following arise from germinal center except. Alright. So if you do this, we are all sorted. Okay, so now we go on to the CD marker approach. Again, we are going to make this very easy. So, how do you approach non-Hodgkin's lymphoma? First of all, you're going to have lymph nodes, you're going to have hepatosplenomegaly here. Look at the CD marker. If it is CD3, this is a marker of T cell. We are dealing with a case of T cell lymphoma. So, one thing you want to remember, cutaneous T cell lymphoma, I've already told you. Pottier's microabscesses seen in mycosis fungoides, right? So cutaneous T cell, mycosis fungoides, Pottier's microabscess. I also told you cerebriform appearance of the nucleus. That's all I want you to remember. If it is CD1920, we are now into the main category of B cell NHL. Now we have to diagnose further. So let's go to the margins. What did I tell you? Does anybody give anything to the marginalized? Never, right? So 5 negative, 23 negative, 10 negative. We are the marginal zone lymphoma or maltoma. Maltoma also tells you that this arises from the mucosa associated lymph node tissue. This also arises anywhere you have underlying inflammation. So this is the type of lymphoma that is seen in background Sjogren's, in background Hashimoto thyroiditis, alright. So this is into the mucosa related soft tissue like the bowel, Sjogren's, Hashimoto. So this is marginal. Now if CD5 is positive, look at 23. This is probably the most commonly asked question. Remember, what was the one where all was given? You have 200 also, you have 13q deletion also. This is our all, which was CLL/SLL, and the hallmark which is very frequently tested are these smudge cells. Can you see how they have this very smudgy appearance? So this is the smudge cell. On the other hand, if you have CD23 negative, cyclin D1 is positive. Can you remember where we had cyclin D1 positive? Where did we have 1114? So T1114, this is mantle. So this is your mantle cell lymphoma where 5 is positive but 23 is negative. This is also a repeat question. In certain cases where D1 is negative, you can also get SOX11 positivity. You can get cleaved buttock cells or lymphomatoid polyposis. These are just 2 extra edge points for you. So this is your mantle cell lymphoma. So we've sorted 3 already. I hope you remember marginal translocation. We took the margins T11, 18. Alright. Now we go on to the next type wherein BCL2 is positive, 10 is positive. Anytime you got 2, you have a good prognosis. Same thing I taught you in Alzheimer's. ApoE2 is good prognosis. E4 bad. Here also BCL2 good prognosis. This is the lymphoma with the best prognosis. This is follicular lymphoma. You can be given an image in which the follicles are being seen, lymphoid follicles are being seen. This is follicular lymphoma. So this has the best prognosis. Now if you have CD10 positive and you have BCL6 positivity, then you look at CMYC. You already know the answer. CMYC, 8 chromosome. This is starry sky appearance. Very, very important. We are dealing with a case of Burkitt's lymphoma. So this is Burkitt's lymphoma, Ki67. Look at the proliferation index, 100%. This is a tumor which grows overnight. It has such high proliferation index. You want to remember 2 types here. One is the endemic type, endemic to the Africans. You're going to have a jaw swelling. You can also have a sporadic variant here, in which case you're going to have an abdominal lump. You're going to have an abdominal mass. So this is Burkitt's lymphoma. On the other hand, if they give you all most commons, overall the most common, the most aggressive, the most extranodal associated with EBV, this is diffuse large B cell lymphoma. This is DLBCL. Alright, so these are all of the things that you got to approach. So in essence, you remember the translocation, everything negative, marginalize it. If CD5 is positive, 23 is positive, all positive, CLL. CD5 positive, 23 negative, cyclin D1 positive, we remember 11 mantle. If BCL2 2 has good prognosis, follicular. CMYC is being spoken about, Ki67, starry sky, Burkitt. Nothing is being spoken about, DLBCL. Alright, so this is how we have to solve any question on NHL. Now let's go to plasma cell dyscrasia. So this is multiple myeloma. We now have an updated criteria which is known as the Crab-Slim criteria. So Crab is the end organ damage here, which is represented by Crab. So for a diagnosis of multiple myeloma, you need more than 3 gram of this M protein. This is the gamma spike that is seen because of M protein. What is the M protein? It is the increased immunoglobulin chain. So it is IgG which is in the maximum amount. So you remember more than 3 gram plus plasma cells more than 10% plus Crab manifestation makes for a diagnosis of multiple myeloma. And now the update is they've defined biomarkers with SLIM. So this is the Crab SLIM criteria. What is Crab? Hypercalcemia, renal insufficiency, anemia and bony lesions. What kind of bony lesions? We're gonna see these punched out lytic lesions in the skull, also known as a raindrop skull. RBC, I've already told you there is this rouleau formation because of increased fibrinogen and these immunoglobulins, they stick to one another. And what is the SLIM feature? You're gonna have greater than equal to 60% plasma cell in bone marrow. So these are all of your high risk biomarkers, okay? So 60 instead of 10 is high risk. LI, uninvolved or involved free light chain ratio of 100 or more is again very important, and M means MRI showing you a bone marrow lesion. So this is SLIM, you should know the full form here. As far as the bone marrow is concerned, you see all sorts of names. There are these flame cells that you can see. Apart from that, you can have Russell body and Dutcher body. Remember, Russell body is intracytoplasmic, whereas Dutcher is intranuclear. Alright, so these are all the points you want to remember for multiple myeloma. Now we go on to platelets. Alright, last part of hemat, this is about bleeding disorders. So before that, let's understand the normal physiology here. So platelet plug, how does it form? Let's say that I got a cut here. Somebody hit me and I got a cut. What's going to happen? My body has to respond. So the moment the body sees that, okay, there is some endothelial injury here, the endothelium is torn, the endothelium itself, it doesn't want anybody. Somebody has to start, right? So endothelium is like, I am injured, I will only start. It starts the cascade. So immediately you're gonna have this transient vasoconstriction first of all, and this is neural stimulation and endothelin mediated. So the first step which happens is this vasoconstriction. Let me just stop the blood from coming here before anything else happens. After that, you have this von Willebrand factor which is released from the Weber-Palade bodies. The endothelium themselves store this von Willebrand factor with P-selectin and other thromboplastin, TPA, PGI. To just remember, von Willebrand factor is exposed. This is what is going to invite the platelets. So the moment the von Willebrand factor binds to the collagen, we are going to have platelets coming and binding to it. Okay, so this is what the endothelium has done. It is called one platelet. Rest of it is going to be taken care of by the platelet. Once platelet comes, everybody is all chilled out. Platelet aa gayi hai, ab kuch nahi hoga. So now the platelets have come. It's going to bind to von Willebrand factor by GP1B. Okay, so GP1B is the binder. If this is only deficient, you have Bernard-Sollier. So there is a defect with adhesion. So remember, B is the second letter of alphabet. It is a deficiency of 1. So 1 is Bernard, defect with adhesions. Alright. So this is the first thing. The moment platelet binds to it, there's going to be release of ADP and calcium and TXO2. These are all promoters of the coagulation cascade, ADP and calcium. Once ADP is released, it's going to bind to the receptor. So ADP binding to the P2Y12 receptor now brings other platelet into action. How one von Willebrand factor invited one platelet has to call other platelet friends. So for that, it releases this ADP which binds to the P2Y12 receptor. Okay, so you can have a problem with this as well, or you can block it with an antiplatelet drug. So that's also very important. Once this is done, you're gonna have expression of GP2B3A. GP2B3A is where fibrinogen and different platelets interact and form a platelet plug. This is known as platelet aggregation. So once fibrinogen comes, it will link and aggregate platelets. Okay, so here we have pro-aggregation factors which are thromboxane, reduced flow, more aggregation. Anti-aggregation is PGI2. You want to remember prostacyclins, inhibitor. That is why they cause vasodilation. Alright. So this is what is very, very important. If I don't have GP2B3A, that is Glanzmann's thrombocythemia. If I have antibodies against this, that is immune thrombocytopenia. So two diseases with 2B3A. Now let's bring pharmacology into it. I'm sure you all know antiplatelet drugs. So what if I block the synthesis of thromboxane E2? I will have no platelet aggregation. So that is first aspirin for you. Let's block TXA2. Second, what if I block the P2Y12 receptors? So that is clopidogrel, prasugrel, ticagrelor, or ticlopidine. These are all the new antiplatelet drugs. What if I block 2B3A? Again, the new drugs. Abciximab is a monoclonal antibody, and your Fib drugs, wherever you have Fib coming in, because fibrinogen is linking with these are your 2B3A inhibitors. Alright, so I hope this is clear to all of you. So let's just finish off this table right here. Here you mainly get questions on the classification. Okay, so COX inhibitor blocking the synthesis of thromboxane A2 is aspirin. P2Y12 receptor blockers could be these. So here one more categorization would be reversible versus irreversible. So reversible is the grelors, whereas ticlopidine, clopidogrel, prasugrel is what is frequently used as irreversible. 2B3A are your Fib drugs and abciximab, or you could have phosphodiesterase inhibitor, which are dipyridamole and cilostazole, which are frequently used as vasodilators. Okay, so this is sorted sat. Now we go into coagulation cascade. We now have all of the coagulation factors coming in and forming this strong plug here. So here you could have intrinsic pathway, extrinsic pathway. So extrinsic pathway, the testing of this is by prothrombin time. So you remember PT is played outside extrinsic factor. This is activated by factor 7. Once factor 7 is activated, combines with the tissue factor and activates the downstream pathway. We'll talk about that. Intrinsic pathway is with collagen, basement membrane, platelets. So if that endothelial injury had happened, it's going to be intrinsic pathway. It's going to be factor 12 which takes the lead. So look at this, factor 12, factor 11 and factor 9. So again it is 10 which is activating 10. So you have 7 with factor 3 combining to form 10, or you have literal 10 combining to activate 10. Yeah, so this is so beautiful that factor 7 combines with factor 3 to activate 10, or you have 12, 11 and 9 activating factor 10 eventually. Alright, and you have factor 8 in conjunction helping. So once factor 10 is activated, then it's the common pathway, then 10 gives rise to factor 5 activation, divide by 2, 5 becomes 2.5 nahi hai, so we have factor 2. So 10 to 5, 5 to 2 is what you remember, and 2 to 1. So factor 1 is fibrinogen, so prothrombin to thrombin happens, fibrinogen to fibrin monomers happen, and this is what is gonna stabilize the platelet plug with the help of factor 13. So factor 13 comes in way after the platelet plug is formed. Okay, so this is not tested by PT or APTT. Remember that both will be normal if factor 13 is deficient. This is also known as the Locke-Lorand factor. Alright, so this is also a repeat question. Got this? So here we have the fibrin mesh which is going to stabilize the platelet plug. If I want to degrade this, we would need plasminogen which would activate plasmin, which further causes lysis. So this is tissue plasminogen activator. So if anything is promoting it, that's thrombolytic, breaking the thrombus. So you know these thrombolytic drugs or fibrinolytic drugs. This is what we use in MI, in stroke. Yeah, so alteplase, retaplase, streptokinase or tenecteplase. On the other hand, if I don't want this platelet plug to break, we are going to use antifibrinolytics like aminocaproic acid or tranexamic acid. Very important, we use this in menorrhagia, yeah, very frequently. So this is about the coagulation cascade. Look at one more factor. We have C1 esterase inhibitors which blocks kallikrein as well as factor 12 and 11. So this C1 esterase inhibitor leads to what? It leads to hereditary angioedema. Remember this right here. Kallikrein causes the activation of bradykinin, which increases vasodilation, permeability and pain. Now let's study the anticoagulants right here, right now. So now before we go into the anticoagulants, what you want to remember are the disorders. I've already told you PT is extrinsic, whereas APTT is basically the testing of the intrinsic pathway, right? So let's just look at a patient with a bleeding disorder. If you find that there are small bleedings, petechiae, purpurae are seen and bleeding time is abnormal, look at the platelet count. If the platelet count is normal, then you have to look at the function, isn't it? There must be some problem with the function. So if the restosetin aggregation is abnormal. Restosetin test is a test of Bernard-Salyer. So the diagnosis is going to be Bernard-Salyer disease, which is a problem with GP1B9, isn't it? On the other hand, if there is abnormal ADP or collagen aggregation, the diagnosis is going to become Glanzmann's thrombasthenia, which is a problem with 2B3A. So these are the two tests that you want to remember, that Bernard-Salyer is a problem with restosetin aggregation, Glanzmann's is a problem with ADP collagen aggregation. Alright, so this is about normal platelet count. Anytime the platelet count is reduced, it means that there is thrombocytopenia. So now we want to look at the platelet count. If immature platelet count is more, meaning it's not a problem with the bone marrow is just doing fine, it's somebody else who's eating them up. So this is your autoimmune disorder, ITP, immune mediated thrombocytopenic purpura, wherein you have antibodies against GP2B3A. Okay, so this is what you want to remember, that this is also associated with some diseases like HIV, HCV. So you can have underlying disease, but this is basically an autoimmune disorder where the immature platelet count is going to be higher, alright, meaning the bone marrow is responding. But if the bone marrow is low, then you think in terms of aplastic anemia. It's the problem with the bone marrow itself. There the immature platelet count is low. So this is about platelet side. When they tell you there is ecchymosis, hemarthrosis, clotting time is increased, now the factor is with the second aspect we saw, which is the coagulation cascade. So there you look at PT, APTT. This is how your approach is going to be. If isolated PT is raised, it is extrinsic pathway, so it is isolated factor 7 deficiency. So isolated deficiency is very rare. This could something that could be seen in early vitamin K deficiency. So can somebody tell me the vitamin K related factors? We have already seen this in biochemistry. It is factor 2, 7, 9, 10 which are activated because of vitamin K. So now here you want to remember that 7 has the shortest half-life. So in warfarin or vitamin K deficiency, essentially the same thing, 7 is going to be affected the first, right? So that is why in warfarin or vitamin K deficiency, early change is going to be in factor 7, that is PT being raised. On the other hand, if APTT is raised, then you have to start thinking in terms of intrinsic pathway. The common diseases would be hemophilia. So if they give you a child, look at the inheritance. If it's a male patient, it is likely to be X-linked hemophilia. So what are the X-linked hemophilia? The common one is hemophilia A, and then you have B. So factor 8 Christmas disease is hemophilia A, most common. Factor 9 is hemophilia B. If you have a girl child, autosomal recessive is hemophilia C, which is factor 11 deficiency. Alright, so first DD is going to be hemophilia if it is a child. If it is an adult patient, there has to be two differentials that you have to rule out. One is APLA. We have already studied it, antiphospholipid syndrome. Second is what is known as an acquired hemophilia, where you have factor inhibitors. This is frequently seen in patients who have had repeat transfusions. So the factors get these inhibitors, alright. So this is how you approach APTT being raised. If both are normal, I have already told you the only factor, which is factor 13, is deficient. And when both are raised, you have a downstream problems. It could be DIC, it could be factor 10 deficiency, which is common to both, or it could be deficiency of fibrinogen, so it could be afibrinogenemia. Alright, so this is how we are going to approach all bleeding disorders in one slide. Okay, so this is about bleeding. Now let's just finish off pharmacology of anticoagulants. So here you could have parenteral versus oral. So let's first look at the parenteral anticoagulants. Okay, so here you have three main categories. The first one are unfractionated and low molecular weight heparins. These bind to factor 2 as well as 10. So they activate antithrombin. Antithrombin has an ability to inactivate both of these. So they inactivate both factor 2 and 10. So unfractionated heparin, remember, one side effect, one advantage. Advantage is that it is safe in
renal failure. Disadvantage is heparin-induced thrombocytopenia. The timeline is very important. Around 5 to 21 days you are gonna have thrombocytopenia because this attacks platelet factor A4. Alright, so remember, heparin-induced thrombocytopenia is a side effect of unfractionated. Low molecular weight heparin, that's why they are preferred except renal failure. The examples would be enoxaparin, dalteparin. The only trap is you would see XA and you would mark it as XA inhibitors. Don't do that. So enoxaparin is low molecular weight. On the other hand, if you have selective only thrombin inhibitors, they are known as DTIs, direct thrombin inhibitors. So in the parenteral category we have hirudin, bivalirudin and ergotrobin. What is very important, very frequently tested is the oral DTI, that is dabigatran. Alright, so dabigatran TR is the thrombin inhibitor. Remember, what is the reversal agent of choice? So the dabigatran is idarucizumab. Alright, so idarucizumab is what you want to remember. So DA is how you can remember. On the other hand, factor 10A inhibitors are gonna be XA. They are gonna have 10A in their name. So otamixaban is the only parenteral one. Otherwise, most of these are oral ones. And what is the reversal agent for this or antidote for this? It is gonna be andexanet alpha. Here also you have XA in the name. Okay, so this is about factor 10A inhibitors. Also remember, this is a synthetic form of heparin in which it has higher, in fact almost all of the action is 10A inhibitor. So I've added it here, that is fondaparinux. Okay. We are left with one thing, which is warfarin, which is the oral drug that binds to vitamin K epoxy reductase. It inhibits it so that all vitamin K activated factors, that is 2, 7, 9, 10 could be inhibited. What is the antidote for warfarin? There is no such antidote, but we can give vitamin K, we can give FFP, which is a replacement of all coagulation factors. What about heparin? The antidote is protamine sulfate. Yes, so protamine sulfate is the antidote. Alright, so this is about all of the reversal agents which are very important, that I have highlighted in yellow. In fact, I am going to highlight them one more time in orange so that you remember that these are your antidotes. Okay, so this is all about anticoagulants from pharma. Now we go on to just 2 slides of transfusion medicine and blood grouping. Very easy. So blood grouping, they can ask you this very simple question. If you just do once, then it will be clear. If you don't have the concept, you will get this very simple question wrong. Okay, so now when we are doing the blood grouping, I am sure you know that the blood group is determined by the antigen which it has. Alright, so now every blood group is gonna have the common antigen. Let's just say is the father of all A, B, everything. Okay, so remember that H is gonna be there in everything, whether it is A, B, ABO or O. Exception is Bombay blood group, which does not have any antigen. Alright, so that's what you want to remember, that all antigens are present in all of these blood groups. Now what are the other antigens? So on A we have A, on B we have B, on AB we have both, whereas in O we have nothing else, we just have H. Okay, so this is how we remember the antigens. Whatever is the missing antigen is going to be the antibody. So antibody in A is anti-B. On B we have anti-A, AB has no antibodies, whereas O has both anti-A and anti-B. Whereas Bombay blood group will have all anti-A, anti-B and anti-H. So what is the interpretation of this? The interpretation of this is that AB, which has no antibodies, would be the universal recipient. It has no antibodies, it can take blood from whoever he wants. The other thing is O has no antigen, so it can give to anybody it wants. So O can give to A, B, AB or O, it is the universal donor. But Bombay blood group, it has all antibodies. Can it receive from O also, who is universal donor? No, he has all antibodies. So Bombay blood group person, a very rare blood group, can only take blood from Bombay blood group only. So this is what is the relevance here. O is the universal donor. I am sure all of these these basics you all know. AB is universal recipient, whereas Bombay can only take blood from Bombay. Now, how do we interpret these? So, this is also so simple, but if you don't know the concept, you will get this wrong. So, here, whenever we are doing the blood grouping, hopefully you would have done this once in your life at least, we have these anti-sera, right? So, what you got to do is you take these 4 blood groups and you put 3 anti-sera. Wherever there is clumping, that is the blood group, that is positive. Okay, so what we see here is A is clumping but D is not clumping. So, this is A negative. RH antigen is also not there, D is also negative. Both are clumping, A positive. Only B negative. Both are clumping, B positive. Let's further look when H is mentioned. So, D is clumping and H is clumping but AB are not clumping. So, this is O positive. But when H is also negative, what is this? Bombay blood group, right? So, I'm sure now you've understood this. Also remember the chromosomes, very easy. So, you remember RH chromosome, ABO and then H antigen. So, this is all in order 1, 9 and 19. So, you can remember Rah. Rah means road. So, remember road or Rah, 1, 9, 19. Okay, just 3 names I want you to tell you, which is the antigen which gives resistance to Plasmodium vivax and novel C. It is the Duffy antigen. What is the McLeod syndrome, a defect of? Kell antigen. And antigens which are absorbed from plasma, Lewis antigen. So, just read these names once, that's good to go. Finally, transfusion medicine. So, we use anticoagulants whenever we are storing the blood. So, citrate, phosphate and dextrose. Why citrate? Because citrate sequesters the calcium. If you remember, I forgot to tell you, but if you remember in the pathway, everywhere you can see this asterisk. These asterisks are things which are calcium dependent. So, we need calcium for the coagulation cascade. What citrate does is it sequesters the calcium, and that is why you're gonna have no coagulation in the blood when you've stored it. Okay, so these are the additives, we use them for anticoagulation. The phosphate is the buffer, whereas dextrose gives the metabolism. Alright, so we have CPD. CPDA means where you are using adenine as well to increase the shelf life, and SAGM is what is currently used, disalign adenine glucose and mannitol. What is the storage time in each of these is used? So, just simple CPD was 3 weeks. When we added adenine, it became 5 weeks, but when we use SAGM, it is 6 weeks. Alright, so 42 days is the maximum you can store the blood in. Alright, so 3, 5 and 6. Now let's just do questions on massive transfusion. Lots of questions. So anytime you give more than 10 units in 24 hours, that is the definition of massive transfusion. That has its own set of complications. Very frequently you're gonna see hypocalcemia because too much citrate, right? Too much citrate sequesters all the calcium. Potassium could be high or low. Remember, it could be both. The most common acid base, because citrate is coming in earlier. Remember what happens with citrate is it's an acidic compound, right? So there is metabolic acidosis which sets in earlier, but eventually all of this citrate in the liver gets converted to bicarb. So eventually you're gonna have metabolic alkalosis. Okay, so this is the acid base that you want to remember. What is the most common cause of death? It is a dilutional coagulopathy. Alright, so dilutional coagulopathy, because so much blood dilutes the coagulation factors, you can die of dilutional coagulopathy. So this is about these questions. Now the blood products, what is the different parameters we have to remember? Remember, whole blood or PRBC should be stored at 2 to 6 degrees Celsius. The shelf life, as we have seen with SAGM, maximum is 42 days. You should transfuse a blood that you've started within 4 hours. Like if I start a blood transfusion, it should be within 4 hours that the complete bag is done. 1 unit of RBC, 1 unit of PRBC can increase the hemoglobin by 1 gram per DL or the hematocrit by 3%. Okay, so this is what is the increase. What about platelet? They could be pooled or STAP. They are frequently stored at room temperature of 20 to 24, and that's why there is high risk of bacterial contamination. The shelf life is 5 days if you use an agitator. An agitator is a very routine looking machine, I don't think they'll ask you an image based question, but it basically keeps agitating it. It keeps the bag moving so that the shelf life is higher, so it's 5 days. Without that agitator, it becomes 1 day. Okay, once started, you should transfuse it within 30 minutes. Same for FFP cryo, it should be transfused within 30 minutes. One platelet can increase the count by 5 to 10,000 units of platelet. FFP cryo, FFP has almost all of the coagulation factors. Cryo is very important. So what does cryo have? Cryo has factor 8, cryo has factor 13, and cryo has von Willebrand factor in addition to fibrinogen. Okay, so this is what you can give to 13 deficiency, von Willebrand disease, as well as afibrinogenemia. All right. So remember this. Both of these are stored at minus 30 degrees Celsius and have a shelf life of 1 year, and they increase all of the lives of these factors. There is no specific percentage here. Okay, so this is about the questions. Where you get a lot of medicine questions is this table, complications of transfusion. Every exam you will get one question on this. So firstly, you have fever, chills and malaise, very mild fever around 1 degree Celsius. This is the most common side effect. This is febrile transfusion reaction. Remember, this is non-hemolytic. So this is febrile non-hemolytic transfusion reaction. This is the most common side effect to occur, and this can be reduced by using this device, which is also something which is very frequently tested. This is a leukofilter. This is a leukofilter which can also reduce the risk of CMV. It can reduce the risk of febrile transfusion reactions. If you have fever, chills, pain at the site of reaction, most important buzzword, nausea, vomiting, shock with dark urine, stop the reaction straight away. You are in trouble. What is this? This is ABO, incompatibility. There is a hemolytic transfusion reaction. You have not done the blood grouping properly. It's probably not you who cross-matched it. You probably sent an intern, but who's gonna be responsible? It's you. Vicarious liability, right? So ABO mismatch, it's going to result in hemolytic transfusion reaction. Dark urine, hemoglobinuria is your buzzword. Stop the transfusion, pump IV fluids and diuretics. If you have urticaria, pruritus, heights, it's likely an allergic reaction. It is usually non-serious. Then two most important questions when you have dyspnea. The moment you have dyspnea, please don't mark acute lung injury. Look at JVP, whether JVP is raised or not. If it is not raised, you have infiltrates. This is what is TRALI. TRALI is the most common cause of death, transfusion related acute lung injury. This is related to the HLA antibodies against the HLA to the donor. Remember, you have to stop the transfusion. Two conditions where you stop: TRALI and hemolytic reaction. Alright, apart from that, if they give you JVP is raised, it is TACO. TACO is transfusion associated circulatory overload. Because of the transfusion, there is circulation overload, and here the management would be slow the infusion, pump some diuretics to manage the fluid overload. So this is very, very important. So this marks the end of hematology for us. I have tried to integrate almost everything which I could, and remember, this is very, very important. This is slightly ignored, underrated topic, but in the exam, if you see, it gives you very high marks. Okay, thank you so much. Bye.